I'm just going to go over the clinical assessment of tear stability, which is a big problem. I know that for years I've been trying to convince Joe and Ray that they should try to get a non-invasive tear analysis software in the Tracy. So as I'm going to show you, they are moving in that direction, and it looks pretty promising because of the sensitivity of the device. So tear stability is really the defining feature of tear dysfunction. And as you can see here, all types of dry eye conditions, either aqueous deficiency, the autoimmune type or non-autoimmune type, ocular rosacea or atrophic meibomian gland disease, have a rapid tear breakup time, well under 10 seconds compared to a normal control. And actually, when we found that out in the 1990s, I thought it was really exciting, but it turned out that the famous Danish ophthalmologist Norn had reported that over a decade prior to that. So he was way ahead of his time that noted that tear stability is reduced in all types of tear dysfunction conditions. And tear instability is a consensus criteria in a couple of the latest definitions of dry eye. In the Dry Workshop 2, it was defined as a multifactorial disease in which tear instability and hyperosmolarity play etiologic roles. And then more recently, Kazuo Sabota from Japan put together a global group to define dry from a clinical perspective, and they said that also that it's a multifactorial disease characterized by persistently unstable and or deficient tear film. All of us are probably using fluorescein tear breakup time in our practice, which continues to be the gold standard, and it's the time to the first appearance of a tear break, normally occurring in about 8 to 10 seconds, although there's some just debate about what's the best time to distinguish between normal and tear deficient patients. And more recently, Dr. Yokoi from Japan has reported that there are different patterns of tear breakup. And probably none of us, including myself, get that sophisticated really at the point of care to try to define this, but it probably is important because the pattern and area of the tear breakup may actually help to define the underlying problem. And so he reported that there was, in the most severe dry eye, there's like instantaneous tear breakup. You don't even see the spots. Or there can be a line of tear breakup like you see here in moderate aqueous deficiency or meibomian gland disease. When there's decreased wettability, which he feels is due to a poor mucin layer, then you get the spots in the cornea. And then with increased evaporation in meibomian gland disease, it's more of a random pattern of breakup. But I think there's more and more interest in using non-invasive tear breakup time methods because they provide a digital record which you can go back and look at it and maybe try to identify the underlying problem. Like if the patient has corneal fibrosis or epithelial basement membrane disease, you can actually go back and see consistently where the tears are breaking up in that area. And also fluorescein itself can affect the stability of the tears, so you get a bit of an artifact from that. And there's a variety of non-invasive instruments out there now. I don't know that anyone has dominated the market. And most the methods use a kinetic analysis of smoothness or spacing of the reflected rings. And you can see in a normal eye, the rings are fairly evenly spaced and fairly consistent thickness, whereas in eyes with an unstable tear film, the rings are of variable thickness and variable spacing. So some of the software programs have used that method. But recently, we've had the opportunity to kind of beta test the new iTrace with some of the tear analysis software. And I honestly, I don't understand all of it yet, and I know it's still in development, but I'd like to show you. One thing about the iTrace is that the camera is very sensitive. So this is 1 second. I've just captured a few images over 10 seconds of videoing the tear film, and everything looks pretty good. By 3 seconds, you're starting to see a little bit of distortion in this area and here. In 10 seconds, that even becomes more pronounced. So even just visually looking at it, you're able to detect abnormalities in the tear film. Well, there's lots of conditions that all of us deal with on a daily basis that cause tear instability, including altered corneal sensitivity, systemic medications that many of our patients are on, cosmetic surgery with incomplete eyelid closure, and then reduced lid tension, which will lead to conjunctival chalasis that I'll talk about in a second. The Western diet, which isn't really good for maintaining a stable lipid layer, the environment, LASIK surgery, eye drops that we use, especially prostaglandin analogs and benzalkonium chloride preservative, and then aging. You know, we're all dealing with an aging population worldwide, so that's probably the number one cause for greater instability, and it's also in the population that we're doing cataract surgery on. Well, conjunctival chalasis, I think, is we were just talking with Dr. Henry before, and I think people more and more are recognizing that it's really a major cause of age-related tear instability, and just like the other conditions like meibomian gland disease or aqueous tear deficiency, tear breakup time is more rapid in conjunctival chalasis. And a lot of these people actually have tears pouring out of their eyes, so it's not actually a tear deficiency problem, it's more of a tear distribution problem. And you can see here using anterior segment OCT to measure the area of the redundant conjunctiva. There's an increase both in the temporal bulbar conjunctiva and in the nasal here in the white bars with these increases in age. So it's clearly an age-related process. And the same thing was found in another population-based study in Japan. You can see here they graded the conjunctival chalasis from 0 to 3, 3 being severe enough that it probably could require a corrective surgery. And you can see that while it increases with age, the more severe conjunctival chalasis really starts to jump up around the 5th decade of life, where over 30% of people would have a grade 3 severity conjunctival chalasis. So, you know, many of you probably have patients that are dissatisfied after perfectly performed multifocal IOL surgery. And there's several different studies now that have reported that dry eye or tear dysfunction is a major cause for that. And we look at patients and they look perfectly fine, but they complain a lot. Like this 70-year-old gentleman who was actually done by one of my colleagues at Baylor, perfect surgery, is 3 months post multifocal IOL implantation, had one of the Alcon lenses, and was experiencing frequent eye irritation and displeasure, even though he had 20/20 distance and J1 uncorrected near visual acuity in both eyes. But he was interested in IOL exchange because of the vision fluctuation, blinking and annoying reflections. But he had a rapid tear breakup time at about 6 seconds, and he was blinking frequently, like 40 times a minute, which obviously can wear on you after a while, but may have been one of his problems. And when I took a look at him, you could see that he clearly had very prominent conjunctival chalasis that was disrupting his inferior tear meniscus, and you could also visualize that on anterior segment OCT. So I think that, I thought at the time that was part of his problem, and actually treated the conjunctival chalasis, which improved his symptoms somewhat, but didn't completely eliminate him. But I think it got him to the point that he didn't want the lens exchanged anymore. Or this was another patient in Houston that I saw right after that. He was also complaining of intermittent blurred vision in the temporal visual field after blinking, and this is the Tracy tear film analysis. And I've seen this pattern now in a couple patients, and it's very interesting, and it's given me a new perspective on the problem. He would complain that his vision would fluctuate after blinking, but it was always on the temporal visual field, more in the right eye than the left eye. But look what happened after the over 10 seconds, really the distortion was on the temporal side. And interestingly, you could actually see where his tear meniscus was building up here on the lower lid, and it abruptly stopped in the area of the conjunctival chalasis. So I think part of that problem is that he wasn't distributing tears very well on the temporal cornea. And very interestingly, a lot of patients that report dysphotopsias from IOLs, either multifocal or monofocal IOLs report them on the temporal side. Have many of you noticed that? So it's quite possible that maybe this software will give us some new perspective on these annoying visual complaints, and which would be helpful in trying to manage them, because I know these patients tend to be extremely unhappy. But it's also recognized now that tear instability impacts vision, and I think that's really one of the great features of the Tracy, that they'll be able to combine not only the analysis of the tear film breakup, but also to correlate it with the visual abnormalities that people have. And you know, it's interesting in dry eye, I'm sure all of you notice that they don't, if you measure their vision, it's just like that patient, they'll have 20/20 Snellen visual acuity, but they frequently complain of fluctuating vision, or the quality's not as good. So one study performed by Kazuo Sabota's group in Tokyo compared what they called ordinary visual acuity, which was just measuring vision under normal conditions, and people with dry eye, both Sjogren's syndrome and non-Sjogren's syndrome aqueous deficiency, had logMAR visual acuities that were virtually identical when measured under normal conditions. Like the patient would just, you know, they would just cover one eye and read the eye chart. But after they held the eye open for 10 seconds of gazing, the controls still had the same logMAR visual acuity, but there was degradation of the visual function in both of the types of aqueous tear deficiency. Very interesting. In studies that we've done at Baylor, really following on work that Ray Applegate had done at University of Houston, using 10% low contrast visual acuity to try to identify early cataracts, we thought, well, let's compare 100% contrast and 10% low contrast visual acuity in patients with dry eye, and there was a mean 38% decrease in 10% low contrast visual acuity in those patients. So again, unless you really test them under a kind of a stressed condition, you're really not going to pick up the visual abnormalities. And then very recently, same out of Dr. Sabota's group, Dr. Ko has reported higher order aberrations increase with tear breakup and epitheliopathy. In fact, in Japan, they think that most of the dry eye is actually an abnormality in tear film breakup. They're not that interested in other things, but they look very carefully to what they call the short BUT type of dry eye. So they looked at higher order aberrations and simulated retinal image in normal eyes, and there was while the eye was held open for 10 seconds, there was very little increase in higher order aberrations or decrease in the simulated retinal image. But in the short BUT group, you can see higher order aberrations were greater to begin with and then increased with time, and there was a clear degradation of the image, which even worsened further when there was central epitheliopathy and tear breakup time. So hopefully in the design of the Tracy software package, it'll take into account being able to actually look at the ray tracing and give us an index of visual function. So I think that the eye trace is really a great instrument, and it will assess tear stability as well as visual function using high resolution and placebo-based non-invasive measure of tear stability and ray tracing assessment of visual function. Well, thank you very much. That was my talk, and